Hi, class. We are going to talk about general chemotherapeutic agents. So, we are going to talk about these in context of supplemental procedures or medicaments with non-surgical periotherapy, right? So, we want to remember things like Arrestin that we use in clinic are chemotherapeutic agents. So, we know that after instrumentation, the repopulation of periodontal pathogens at a destructive level can take place within 2 months. And these pathogens can also invade the tissues that cannot be affected by debridement or are not affected. We also know that systemic and local antimicrobial agents can help eliminate and or control pathogens and their effects on the periodontium. So, like I said on the slide before, we're going to talk about these supplemental procedures that use chemotherapeutic agents, such as Arrestin. What is a chemotherapeutic agent, you might be wondering? So, chemotherapeutic agent is a general term for a chemical substance that provides a clinical therapeutic benefit. Right, so again, remember this is a general term. So chemotherapeutic agent can be used in lots of healthcare settings and for lots of different pathogens, right? This is just a general term. It can be used through antimicrobial actions or through an increase in the host resistance. Antimicrobial agents are chemotherapeutic agents that work by reducing the number of bacteria present. So, an example that many of us have used many times are antibiotics. And they are a type of an antimicrobial agent that destroys or inhibits the growth of selective microorganisms. This is why when sometimes you have certain illnesses, you may not just be prescribed like amoxicillin, as long as you're not allergic to amoxicillin, right? But so you may be prescribed something different. I know for me, like whenever I have needed antibiotics, I always prefer to get things like the Z-Pak, the zithromycin, and I like it because it's quick. It's only a few days. It's a higher dose, so I don't have to do it for at least 7 to 10 days like you do amoxicillin. But it is not always the best option depending on what type of bacteria I have present that's causing the illness. So before we dive into those local antimicrobials like Arrestin, we're going to talk about some systemic antibiotics. So in general, systemic antibiotics reach pathogens in the pocket, if we're talking about periodontal disease, through the circulatory system, right? So you take these medications orally and they reach the periodontal pocket or the sulcus through the circulatory system. So they have to pass through everything. They are absorbed into circulation through your intestine, and then they're passed into the body tissues. And they enter the periodontal pocket through that crevicular fluid. Now, this type of systemic antibiotics, they can become diluted by the time it reaches the pathogens in the pocket, which makes sense because it has to go through this whole process to be absorbed. So we're talking about systemic antibiotics, something that you would take most likely orally. If systemic antibiotics are used, which they do sometimes, we want to make sure that we specify the microbe that's causing the disease. We have to figure out which microbe is causing the disease. So certain antibiotics are not going to be helpful for periodontal pathogens like they would for a sinus infection. Then you're going to select that antibiotic that's specific for the microbe, and testing can be available to help guide those clinical decisions. I mean, how are you going, if you need to specify the microbes so that you know what antibiotics you need, think about some of those ways that you would be able to determine what kind of microbes are causing. One way is that we just know of certain microbes that are inherently related to periodontal disease. So you can just go off of those general terms. But there are ways now that you can do like salivary or even pocket kind of biopsies or samples and have those sent off. So a common use of systemic antibiotics is tetracycline or metronidazole. Always trips me up, right? And these are often used to treat those early onset aggressive periodontitis. So that's not always the only type of antibiotic that's used. Penicillin or the amoxicillin and augmentin can be used, the tetracyclines. But what population of patients, remember, are we going to avoid tetracyclines in? Those that have an allergy to it, of course. But we avoid tetracyclines during pregnancy. We have the quinolone, macrolide, lincomycin, and nitromidazole. I'm really butchering some of these, I think. But tetracyclines are common also once we start talking more about some of those local antimicrobials. Because we know that tetracycline, the minocycline, the doxycycline, the tetracycline can be helpful in treating those specific microbes related to periodontal disease. So we have some guidelines for use of systemic antibiotics. We rely on that clinical diagnosis, the continued disease activity. We're looking for criteria for specific antibiotics. We may take microbial samples. We can perform these at any appointment. And then the results may indicate that something is needed. These are not used as a monotherapy, and they may be used to enhance regenerative healing. So sometimes antibiotics will be prescribed like during non-surgical periodontal therapy. I haven't had that be a really common reality in dental offices and practices that I've worked in, but I have experienced it before. And if you work in a periodontal office, they often will prescribe antibiotics, systemic antibiotics, in conjunction with periodontal therapy, especially depending on the type of periodontal disease that's being treated. So it's not out of the norm, but a lot of times in your general dental practices, it is not very common. And maybe it should be, right? So, as a dental hygienist, that's always something that we can do research on and help to implement a new system and protocol, right? You take some CEs, you learn um, new information, hear about new research, new recommendations, new therapies that are out there, and we may be able to implement those within the practice that we are working in, whether it's in your kind of more common traditional dentist dental hygiene setting, or even a dental hygienist that's working direct access without a dentist on site. So these are all things that we can take care of ourselves. We can make those changes within the practice. But I have had some minimal experience personally with systemic antibiotic use. Now, of course, there's limitations, as there are with anything, And some of the limitations with systemic antibiotics are possible undesirable side effects. I know I did do some systemic antibiotic use, we really had to make sure that patients understood the need and importance of certain additions to their diet, especially making sure they didn't take antibiotics on a empty stomach because they were some stronger antibiotics that we were giving them and they could make them feel sick if they had an empty stomach. We know that with antibiotics, there's that potential for resistant strains to develop. And this is also why we stress to our patients that they take and complete their full regimen of antibiotics when they are prescribed. That localized concentration is diluted, especially whenever we're talking about systemic antibiotics that are being used in the treatment of periodontal disease, which is in a very localized, specific part of the body. We can also cause superimposed infections if we are killing off too much microbes within the body, and then patient compliance, right? Because this is something that we prescribe to them and they take home. And so we have to make sure that they actually are taking it. So when we're talking about these chemotherapeutic strategies, a common term that you will hear, and like a lot of things that I feel like I say in class, I think with time you are going to be hearing these terms even more throughout your career than I have at the beginning of my career. But one of them is host modulation. And this is a therapeutic strategy that aims to disrupt immunoinflammatory responses. So host modulation is not limited to just periodontal disease, but those immunoinflammatory responses, such as like rheumatoid arthritis, just regular arthritis, and those types of other systemic diseases that can occur. So this table shows some host modulation therapies. Now, these are just general therapies. These are not specific just to dental hygiene. These are host modulation therapies in general. And when you look at the far right, you can see that there is only one, the doxycycline, that is approved for the treatment of periodontal disease. It's also used for acne and rosacea. So when you read through this chart, don't look at it, and especially when you see bisphosphonates, and then you think back to medical emergencies and you think, well, wait, Miss Westhoff said that bisphosphonates can cause osteonecrosis, and now it's on a list for host modulation, and we're talking about periodontal disease. Well, yes, it is, but bisphosphonates are not utilized to treat periodontal disease. They actually have the opposite effect that we want for periodontal disease, right? So this list of therapies is not limited to periodontal disease only. But it's important to know that there are other immunoinflammatory disrupting therapies, and there is ongoing research with some of these, like non-steroidal anti-inflammatory drugs in conjunction with other medications, and things like that, to see if some of these host modulation therapies could also benefit periodontal disease, because we know it is an immunoinflammatory response. So this just helps give us a broader view of those host modulation. So what are some of the requirements? We talked about some of the systemic antimicrobials, right? But what about those local antimicrobials, like Arrestin that we use in clinic? So we want to make sure that the concentration is at a level that will act on the microorganisms causing the infection, right? If we don't have a high enough dose, it's not going to do us any good if we put it in that pocket. We want it to reach all areas of the pocket, and we need it to stay in contact long enough at the effective concentration for the antimicrobial action to take place. So think of your Arrestin. You tell your patient that they aren't to floss for 10 days in the area where you've placed Arrestin. You tell them not to eat crunchy foods for the day. You give them a date that they can start flossing again, because of course we don't want them to hear us wrong and think that you said not to floss at all. So that's where that staying in contact long enough. We know that Arrestin needs to stay for a certain period of time so that it is able to have its most therapeutic effect on the pocket that we are treating. And we need to be able to get it into the pocket. So, what are some of the times that we can use these slow release local antimicrobials like Arrestin? We can do them at our initial non-surgical periodontal therapy, which we got a little double therapy in there, NSPTT therapy, non-surgical periodontal therapy. So we can use them then at the time of treatment. We can place them at reevaluation. We could place them at subsequent periodontal maintenance appointments for recurrent disease. We could use them for peri-implantitis, right? Because we know with our implants, we can't get decay around an implant, but we can definitely get peri-implantitis, periodontal abscesses, furcations, those hard to reach areas. And it can also be used in preparation for periodontal surgery. So not just the non-surgical perio that dental hygienists can provide their patients, but if someone is going to have periodontal surgery itself, where they're going to do a gum flap. These local antimicrobials can help to prep that site of surgery so that they have a better outcome. Now, if you place local antimicrobials at your non-surgical periodontal therapy, that initial treatment, can you place them again at your reevaluation? And could you even place it at their 3-month perio maintenance appointment? Of course. We can place them multiple times, which we know in our clinic setting in school is wonderful because we can place those really at almost no cost to our patients. Where in a practice setting, they're going to have to, pay for that care each time. So historically, some of the local antimicrobial medicaments was actisite, which was a fiber. And it was first locally delivered through slow release antimicrobial. It was the first one that was developed. It was an ethylene vinyl acetate, and it was a fiber that was impregnated with 12.7 milligrams of tetracycline. So it was non-biodegradable, which means that it maintains a high concentration for a full 10 days. It was expensive, or is, and difficult to place. Actisite fiber is not something that's available in the US currently, but it helped lead the way for some of the local antimicrobials we place now. So the one that we've talked about more and that we have used in clinic is Arrestin. Arrestin is one of the more readily available antimicrobials in the US. And so this is most likely the localized antimicrobial that you will encounter and use outside of school. So it's a 1% minocycline HCl microspheres. It's bioresorbable, and it's applied in a powder form into the pocket, and it adheres to the walls of the pocket. And it has a sustained release from 14 to 21 days, but it's up to 14 to 21 days. So that's why it's important that we tell our patients to wait that 10 days before they floss, because we don't want them to floss out those microspheres. And we know when we place Arrestin, right, the deeper the pocket and the more inflammation we have in that tissue. For those of you that have gotten to place multiple doses of Arrestin, it's much easier to place in locations like that, right, to really force that powder. But we can place this even in a 4 millimeter pocket if we need to. But Do we need to if it's a 4 millimeter pocket? Right? So we're assessing our patients to determine the best treatment for their needs. So we also have atrodox. This is not something that is common in our clinic at all. And I haven't seen atrodox in a while in the United States. That's not to say that something won't come back, though. This is a doxycycline hyclate, 10%. And it's mixed in syringes and then delivered by cannula into the pocket. This is the liquid that gels when contacting moisture, which of course we know where moisture is present is in the mouth and especially in those sulcus. And then lastly, we have the periochip. I do not believe the periochip is available, not readily anyways, in the US. When I was in school and I graduated back in 2007, we did learn how to place periochips. We had periochips instead of Arrestin. So they have been around in the US, but they are not very common. They are a 4 millimeter by 5 millimeter, 0.35 millimeter thick, orangish brown, hydrolyzed gelatin chip. So it looks like a really, really tiny, thin triangle that's also an orangish brown color. And it's impregnated with 2.5 milligrams of chlorhexidine. It's biodegradable and it maintains those chlorhexidine levels for 7 to 10 days. So it can be very effective. My personal experiences with periochip versus Arrestin is that Arrestin is much easier to place and it's more comfortable for the patient. The periochip could kind of give you the feeling, especially initially, until it kind of got a little more flexible after it'd been in the sulcus, to feel like you have a popcorn kernel stuck underneath your gums. Right? So that's really hard for our patients to leave it alone. They want to pick at it and pull it out. But it had similar rules about flossing and things because we didn't want to floss that out. So what about the future? One thing are some of those host modulation type of therapies that we talked about before. Those are potential in the future and very well could be a reality for all of us within our careers. But one of them also is the metronidazole gel. And it's in a suspension of 25% metronidazole benzoate. It's delivered by a cannula, right? So it's really thin and you can go under the gum tissue. And it's biodegradable with a sustained effect of 24 to 36 hours. So a much shorter sustained effect. It's specifically active against anaerobes, and it does not destroy aerobes simultaneously, right? So it's focusing on those anaerobes, and it's currently not used in the US. So like we've talked about other things like SDF, sometimes these medications and medicaments will begin in one country, and once they have become utilized there and more common, then they will be passed on to other countries and back and forth. So a lot of that comes with research and use and realizing, the positive effects that medicaments can have. Or maybe realizing that maybe one country started with one medicament to address something like periodontal disease, another country started with another one, right? They were researching them simultaneously, and they both were seemingly effective, and one may, with time, be discovered that it's better than the other one. Or maybe that medication started out treating one thing, and they discovered that it was even better at treating something else. That happens a lot when it comes to medications and medicaments and therapies. You start reading about therapies and different treatments, and you will find so often that they began as one thing and they may still treat that, but then they find that it does an excellent job at treating something else. And usually it's because they have similar responses, like they're something similar to like an inflammatory immune response. So those are things that we would then cross research. So if we're not going to do local antimicrobials, we can consider those host modulation therapies. Doxycycline hyclate, 20 milligrams, BID, which if you think back to your farm, BID is twice a day, is Periostat, and it's a minimum of 3 months. And this reduces excessive levels of damaging enzymes. So doxycycline hyclate can be an excellent option for our patients. We do not currently prescribe that in the dental hygiene program, but it may be something that we're able to implement in the future. At this moment, we use local antimicrobials of our Arrestin, and then we also know that we have our laser therapy that we're able to use. But doxycycline hyclate is becoming more common, and that is a host modulation therapy. So I'd remember that one. And then, of course, whenever we're talking about the host response in periodontal disease, we remember that the host response is more damaging in the disease process than the direct effects of the pathogens themselves, right? Because we have changes in osteoclast activity because of those cytokines and those prostanoids. And so often that's where that inflammatory response has such a negative effect in diseases such as periodontal disease, because it's not just the pathogens that are causing the destruction, but our own host response. And that's why host modulation therapy can be helpful if we have a host modulation therapy that's beneficial. And I hope that things like Periostat will become more common and more routine as time goes on. Again, it comes down to the research. It comes down to that marketing, in the sense of not marketing in the sense of like buy me, make money, but the marketing in the sense of getting the word out so that providers, including dental hygienists, know about it. Now, we've talked about these locally delivered antimicrobials. Who can use them? Who can apply them? And depending on each scope of practice for different stage, dental hygienists can apply and prescribe these type of medications. Now, I really emphasize the fact that it depends on the scope of practice. I can more specifically speak to you about the Colorado scope of practice, but each state is different. So let's talk specifically about Colorado's Dental Practice Act. So in Colorado, dental hygienists can prescribe, administer, and dispense if they have a collaborative agreement or an articulated plan with a licensed dentist, a Colorado licensed dentist. So dental hygienists in Colorado can administer, prescribe, and dispense things like fluoride, fluoride varnish, SDF, antimicrobial solutions for mouth rinsing, and other non-systemic antimicrobial agents. What were we just talking about? Non-systemic, right? We did talk about systemic antimicrobials. Those would have to be prescribed by a dentist in Colorado or a physician. But non-systemic, aka local, can be administered, prescribed, and dispensed by a dental hygienist, whether they work with or for a dentist or not. Now, if you do not work with or for a dentist, then you are practicing unsupervised dental hygiene. And in Colorado, there are lots of things that we can do unsupervised, but there are often rules and regulations and requirements in place for certain things if we are practicing unsupervised. And prescriptions are one of those. And localized antimicrobials fall under that. We call it prescriptive authority in Colorado. So dental hygienists can prescribe, administer, and dispense things like fluoride, fluoride varnish, SDF, in accordance with this subsection that we will talk about, that also relates to antimicrobial solutions for mouth rinsing and other non-systemic antimicrobials. But if you read down at the end of this first bullet point, it says that an articulated plan with a collaborating dentist for dental hygiene prescribing. So if you are working unsupervised, then you need to have an articulated plan in collaboration with a dentist. And there are lots of hygienists across the state that have those. But that means that we can prescribe, administer, and dispense things like local antimicrobials in unsupervised dental hygiene settings. And if you look here, if we look down at this long list, we have chlorhexidine gluconate rinses, chlorhexidine gluconate periodontal chips, that's the perio chip, tetracycline impregnated fibers, there's your Atrodox, doxycycline hyclate periodontal gel, we just talked about that one, and minocycline hydrochloride periodontal powder, which is Arrestin. So when you look at this, you know those were all put in there for a reason, right? And the attempt, if I'm giving CODHA a little plug, for the Colorado Dental Hygiene Association, is that with time, we make these terms even more broad, right? So that it's not specifying essentially certain products, because we know the research and the recommendations change. So here's a quick little graph that helps show you some of the supervision requirements in Colorado again, because I know not everyone's staying in Colorado and will not always be licensed and working in Colorado, but it is kind of a great place to work as a hygienist. But whenever we're talking about things like localized antimicrobials, we're going to fall under this prescriptive authority here that's at the bottom. And you can see how supervision required, it says none. But if you come down here, there's an asterisk there, and it requires a written articulated plan. Same thing as silver diamine fluoride, and that's because silver diamine fluoride falls under prescriptive authority for dental hygienists in Colorado. Right, and then we have those specific things that we noted here. But you can see a lot of things we do not need supervision in Colorado for. We do need direct supervision for nitrous oxide. That's the only one that is only direct supervision. Localized anesthesia, it'd be really great if we could get that to be unsupervised, especially for dental hygienists that work in rural settings and areas where there is not a dentist present. But this is why we are able to use localized anesthesia without Dr. Myers being on site, is because we do it in an indirect way. He is aware that we are completing localized anesthesia when he is not on site. But the direct supervision is why we only do nitrous oxide on certain days of the week in clinic when Dr. Myers is present, because you have to have a direct supervision, which means a dentist is there and can see you doing it. We can also do lasers because it's indirect, direct, or telehealth also. And interim therapeutic restorations, which we don't currently do, but hopefully we'll have some abilities to do that in the future because new legislation has passed and changed the requirements for that. Um, that we may be able to teach that right in the midst of all the other dental hygiene things that you learn. So those are the ins and outs of local antimicrobials in general, and a little coverage on some of that systemic, and then those host modulation type of treatments. So if you have any questions, email, text, call, ask each other, but make sure that you get your questions answered. All right, everybody have a good day.